Hello and welcome to the Birth Untethered podcast. I'm Shellie, a long-time doula, advocate and former university lecturer.
And I'm Kemi, a badass birth keeper, formerly a UK registered midwife.
Just a couple of rebels with decades of combined experience in pregnancy, birth and beyond, getting together to share wisdom. We exist to equip birth workers, families and seekers of truth with informed choice, not fear. Come as you are, learn what they don't teach. This is the Birth Revolution and you're all invited.
Hello, everybody. Hello, my friends. Kemi,
Hello,
good
my
to see
love.
you
It's very good to
in
see
the
you.
sunshine.
Oh, yeah.
Welcome, everybody, to Season 2, Episode 11 of the Birth Untethered podcast. And today we are continuing our journey through the many reasons medical professionals believe that induction of labour is justifiable to encourage you into. And we're exploring our experience, the evidence around the benefits or not to this intervention, so that you can have some hopefully helpful information to help you make the decision that feels right for you. And in case you missed our last episode, this is a part 2. So please do go back and listen to part 1 in case one of the reasons that you're being offered induction for was covered in that episode. And if it wasn't, the chances are that we'll cover it today. And if everyone who was pregnant listened to our podcast, I think we'd have a pretty massive impact on the induction rate in the UK. And I think it needs a pretty big impact because, as we heard from episode 9 of this season, our outcomes in the UK are looking very shit compared to countries that don't have such massive increases in induction and caesarean rates. Before we dive in, do you have anything to share from the sunnier, warmer climes? Anything to make us jealous?
Oh,
Envious of the
so much.
How are your pomegranate trees?
My pomegranates are looking so ripe and juicy and heavy. So yeah, just excited about all the ripe fruit out here. You know, as you'd have heard, my little aside. It was last episode, isn't it? I'm a big fan of things being ripe. So I would say the biggest public health tragedy that we are enduring in the Western world is the arrogance of thinking that we can kick babies out of a process on a whim or on the calendar. And especially that so many babies are kicked out without any evidence to support it. I'm shocked that parents are not standing in that gap for their children like I'd have thought they would. Yeah, that's all I've got to say.
I think it's a symptom, isn't it, of our education system, which is obviously hierarchical in nature, was set up to create good factory workers that do what they're told, respond to the carrot and stick approach to things. Yeah. And that hierarchy, those kind of hierarchies are continued in industrialized medical care. And actually, I saw it this week that there was a post celebrating a midwife, and they gave her a gold star, a Star of the Month award, for when a woman who was expecting to have a home birth rang up, and this midwife on the phone said there was nobody to come out to her. Could she come to the hospital? And the woman said, no, I can't. The baby's about to come out. I can't get there. And so the midwife hung up and there was a big scramble, and then she was able to go with her other midwife colleague to the woman. So in my mind, I'm like, right, okay, so they did have somebody to go out to her, but they told her that they didn't. So they've kind of gaslit her into thinking there isn't someone available. But this midwife is being celebrated for going above and beyond because she was a triage midwife and wouldn't normally be going out to home births. So we're celebrating a woman being lied to, a service not being adequately staffed to be able to have somebody to go with her when she was expecting them. And then this midwife is being celebrated by being given a gold star rather than being paid properly, rather than having enough breaks, rather than, you know, being given good, adequate education, chance to do continued professional development, etc., etc. And this woman is feeling like so grateful for this basically scraps of care that were scrambled together in a mess.
Yeah.
And people are just, oh, she got a gold star, isn't she great? She got a star for and it's like people are stuck in primary school, getting gold stars for good behaviour and not realising that this gold star is covering up massive gaps in the system. It's covering up the shit that is happening that means that the midwives are overworked, underpaid, the unit is understaffed to such an unsafe level that they're trying to tell a woman who's just about to have a baby that she needs to get in a car and come to a hospital rather than send somebody out to her. I mean, we know the levels of people choosing to home birth are frighteningly low. They're so tiny. Why do they not have enough staff on call to cover more than one home birth in a month or any home births in a month? So many times people are going, there aren't enough staff. Why aren't there enough staff? You know how many women are likely to be birthing at home. So why don't you have people that can cover that? It's just not okay. And the gold stars just, it made me cross. Anyway.
Yeah, it should. I mean, and just to add to what you're saying, and I love that you're bringing this up, because actually, everyone wants to give this triage midwife a gold star for actually doing her job. Like, if you can't assist someone who's basically doing the job by themselves, all it means is that you're there just in case the wheels come off. Right, which hardly ever happen. With a birth like that, where the woman's saying, "Oh, the baby's coming, I can't leave my house," you know, things are really straightforward, right? So she's received a pat on the back when 6 months ago they were burning midwives at the stake, who also hardly ever saw a home birth. And that time the woman needed assistance, and they weren't skilled enough to give it, and nor the paramedics either. So this is a very dire situation. So I don't think any gold stars should be awarded right now. Okay? We need to fix what's been given.
It's literally like papering. There's giant cracks and problems, and the building is falling down, and people are like, "Oh, I got a gold star! Oh, they're giving out gold stars." It's just like people. It's literally like an institutional level. Look over there. Let's celebrate.
That's right.
Well,
that's right. You're right. A whole institution, a whole culture, a whole society saying, "Look over there. Oh, she's been such a great midwife." Like, the bar is set so low.
And also it's putting pressure on midwives to be heroes, to hold up a crumbling system, which is unfair for them as well. She doesn't need a gold star. She doesn't need a gold star. She needs good quality training. She needs good quality support. She needs good quality mental health support. She needs to be paid a decent amount of money. You know, it's insulting. It's insulting to the mother. It's insulting to the midwife. And, you know, it's just, fuck off with gold stars.
100%. Poke your fucking gold star. All right?
Where the sun don't shine.
Where the sun will never shine. Yeah.
Okay.
Yeah.
Put the gold star with your chocolate star. There you go.
Oh, that's me. I'm sorry. You always have to up-level the insult.
I'm sorry. Just to be clear, I mean the institution. I don't mean the midwife, because, you know, the midwife went above and, you know, we did go above and beyond and try to look after a woman in need. So, you know, great. But, anyway, okay. So last time we ended with speaking about polyhydramnios, which is increased fluid. So it makes sense in my mind to begin this episode with another reason they might give you to try and evict your baby early, which is oligohydramnios, which means a guess, remember it's a guess,
minimal,
that the amniotic fluid levels are low. And again, there aren't exact levels at which outcomes are definitely much worse. These things are estimates. One person may be more affected than another, and one baby may be more affected than another. So take everything with a pinch of salt and a whole heap of your own intuition as to what feels best for you. So technically, oligohydramnios is classed as having less than 500 ml of amniotic fluid. Okay, or if they're measuring the biggest pool of amniotic fluid, it will be smaller than 2 centimeters. Or if they're using an amniotic fluid index of combining the pools around the baby, it would be less than 5. Now, mild oligohydramniosis is often associated with a post-dates pregnancy due to normal physiological changes that are happening in your baby. Their kidneys are becoming more mature, they're swallowing more, etc. So they're reducing the amount of amniotic fluid. So their amniotic fluid is basically the amniotic fluid that they've swallowed and they've weed out. Swallowed, weed out, swallowed, weed out. So as their kidneys become better, they wee out less. And as they get used to swallowing and are better at swallowing, they swallow more. So the amount of fluid goes down. There is a lack of evidence, surprise, surprise, to support induction.
No.
For
Is there a lack of
oligohydramnios.
evidence supporting induction?
Yeah, funny
Wow,
that.
this is becoming a pattern. This is becoming a pattern, isn't it?
Yeah, it is a pattern. I feel like it feels a bit like Groundhog Day, that we're repeating ourselves for every single reason that induction is not.
Seriously.
Yeah. Oligohydramnios has not been associated with poor outcomes
With improved outcomes.
other
Oh.
than the risk of unnecessary obstetric interventions. That's what the research tells us.
Again, yeah.
So there's a lack of evidence to support induction for oligo with otherwise uncomplicated pregnancies. It has not been associated with poor outcomes other than the risk of unnecessary obstetric interventions. And that's literally what it says in the research. So having slightly lower fluid levels if without any other complications is not a problem unless obstetrics gets involved and causes complications. Oligohydramnios can be a consequence of reduced urine output of your baby, and that can be as a consequence of reduced placental circulation. Okay, so if you are having significantly lower fluid levels, it is worth checking out to check the placental circulation to make sure that everything is okay. And that would involve having a Doppler scan. Okay, and what's important to say after that is that if there is compromised placental flow, it is ethically questionable for me to then recommend induction, because if you've got reduced placental flow, your baby's got reduced blood flow, they've got reduced oxygenation, their glycogen stores are important for birth and especially induction because it's more stressful. It's associated with causing more hypoxia and fetal distress. So if there are concerns about your placental blood flow, they should be offering the option of cesarean rather than induction. You know, if we've got fetal growth restriction, you should not be being offered induction for that. NICE guidance is pretty clear about that. Okay.
Really? I think it's literally one sentence, isn't it? It's not even a debate. It's just like saying not suitable.
Yeah, don't do it, basically. And what I'd say is often, I think I've had people who have gone and their fluid levels have been a little bit low and it's raised all kind of warning flags. And actually, if they have a drink and then go and get scanned and the levels are normal. Okay, so the levels fluctuate.
Evidenced as well.
Worth getting rechecked.
Evidenced.
Yeah, worth getting rechecked. Okay, I think probably the favourite reason at the moment is the post-dates pregnancy. That's the reason. And the post-date, I'm going to,
Shellie,
we do, because it's important.
Need to talk about it?
We do, because people are being suckered. People are being suckered. So I'm going to do post-dates in inverted commas, okay? And that seems to be getting earlier and earlier and earlier. Okay? Used to be that everybody thought that normal gestation was up to 42 weeks. Okay? And now they seem to be, well, in a NICE guidance, they're offering women sweep from 39 weeks. So you're not even at term and they're offering you induction. Madness. Your baby's not ready unless they're coming out.
So they're at term, but they're just not at that fictitious due date. Their term,
but it's
from 37 weeks. But I
doesn't mean they're ready though, does it?
Oh gosh, of course not. Of course not. The thing about, so you've got your post due and you've got your post term, right? So post term, just like Shellie said, the normal expected range of birthdays for babies are between 37 and 42 weeks. But the ones post 42 weeks, their post term But that doesn't mean that they're late, and it doesn't mean that anything is wrong either, because you've always got your babies that are born post 42 weeks or pre 37 weeks that are coming when they're ready. And we should be able to understand that. But when the cheek of it, when we know, and well, now if you try to do these figures, you won't be able to do it because so much interference is happening. But, back in the noughties, so, they still had good evidence to show that the vast majority of babies come after 40 weeks. So if you've got the nice guidance suggesting to try and kick the baby out at 39 weeks, that's just pure malevolence. There's no excuse. It's inexcusable. There's no evidence to support it anyway. We know this, but it's inexcusable. Psychologically, you've got to wonder where a healthcare professional is at to actually think that's an all right suggestion. It's malevolent. We know that the vast majority of babies aren't going to want to come at 39 weeks, but we'll just poke around up inside their mothers anyway. What's your excuse?
We expect babies to come until at least 41 weeks.
Yeah,
most babies don't come till 41 plus 3, 41 plus 5. I've had the occasional
Your first
babies.
Yeah, exactly. Okay. And it's always notable. If a first baby comes before 41 weeks and 3 days, it's always notable. It's like, oh, interesting.
But people are panicking because they think that their due date is when their baby's supposed to come. And I think people don't realise that only 4% of babies do come on their due date, that it's a guess, and that actually the guesses aren't accurate either. And they do dating scans as if it makes it a lot more accurate, but it still doesn't, make it to a day. It doesn't even make it to a week. It's really a week or more in either direction. So,
even at 12 weeks, you've got,
even with the 12 weeks
7-day difference. But even then, when I was being indoctrinated into midwifery in my training, even then we had the sense to know that if there was a difference in the LMP due date, last menstrual period due date, and the scan date of less than 7 days, we wouldn't dare change the date. But now they do. They change it as if it's accurate, even though we know that the scan date is a plus or minus 7. How dare you say, oh, there's a 3-day difference in those days, so we're going to change it to the scan date? How dare you?
Yeah, they don't believe you. They don't believe you know when you've had sex. And also this kind of reliance on technology is very dangerous. I think we spoke about it recently in an episode about how, it's dangerous in other areas where people start to rely on technology, like on planes, where the other sensors are telling the pilot that something wrong. But if the monitor is saying, oh, no, it's this, that people will believe the monitor over their own senses, even when there's lots of data from their senses showing that it's not right. And we get this as better, mums will be going, no, I'm definitely not pregnant. I wasn't pregnant then. That's too early.
I wasn't pregnant then because he wasn't in the country.
Yeah.
He wasn't actually in the country, so I wasn't pregnant.
No, but the scan knows better than you. The scan knows better than you. You must be wrong. Oh.
And whilst we're here, mamas who have IVF or any kind of assisted conception, that still makes your due date no more accurate, because babies choose to gestate for differing lengths of time. So please don't think, oh, I'm going to have this argument out with my caregiver because I actually know my implantation date. Still makes no difference. There's usually a gap of 5 weeks in which your baby may come. The bell curve shows a peak beyond 40 weeks. And you'll have some babies coming before the 37 weeks and after, even if you know your implantation date. So just let it go. Let it go. Okay?
Just let them come when they're ready. And you know now
Yeah.
you're not going to be pregnant forever. If you've listened to a few episodes ago, you know you're not going to be pregnant forever.
Yeah, facts.
Yeah. And, our most recent data basically shows that induction at 41 weeks, if they're inducing people at 41 weeks, that you would need to induce over 1,830 or more people unnecessarily in order to potentially prevent one stillbirth. Okay. But that will increase the number of babies in neonatal intensive care. Okay, so for a risk of stillbirth with no signs of any problems, you've gone all the way up to this point in your pregnancy. You've gone 9 months without worrying that anything's wrong. If there are no signs now, why are you worrying so much? Because the risk of stillbirth remains below 1% if you don't have any other things going on. If it's literally just dates and there are no other concerns, I'm just not convinced it's ethical to put that many people through an induction, mothers and babies, through the stress of reduction to reduce the risk. Because what you're doing is reducing the risk from 1 per 1,000 to like 1 per 1,000 because of induction and the risk of induction and the risk of cesarean that often cascades. So you're switching from a very small stillbirth risk to a very small death risk from having an induction or a cesarean, also adding on all of the other things that happen with induction that have long-term health implications, that have short-term health implications, that mean you and your baby are more likely to be injured. Just seems a bit weird, because at 41 weeks, the increase in chance of stillbirth is 0.097%. So it's less than 0.1%. And with cesarean, maternal immediate death risk is 2 per 100,000 compared to 0.2 per 100,000. So it's 10 times the risk. And with uterine hyperstimulation, which can happen with induction medications, the risk of maternal death is 0.1 to 1.3. And if there's, so it's higher than the risk of stillbirth that you're trying to avoid. And if there is uterine rupture, the risk of infant death is then 2 to 10%. And hyperstimulation occurs in 1 to 5% of induced labours using hormonal methods. So it's not that you are exchanging a tiny stillbirth risk for no risk. You're exchanging one risk for another risk, which for me feels more significant. I don't know. I mean, obviously it's up to you, but for me, the week of gestation makes such a tiny difference that if there weren't any other concerns, it would just be a hell no from me. It's not enough of a reason in my mind. But, other people have other ideas. And doctors often like to conflate the risks. I mean, I had a woman told that she had to make a plan. You have to make a plan. They love to make plan. You have to make a plan because you're going to be 41 weeks on a Sunday and we don't do things on a Sunday. You have to make a plan. And she was like, well, the plan is I'm just going to wait for my baby and body to be ready. You can't do that. We have to have a plan. What if we're busy? And I said, okay, so what you're saying is that if her baby's life was at risk, you'd be too busy to give her an induction or a cesarean? No, that's not what we're saying. I was like, oh, okay, so why do we need to make a plan other than her waiting for her body and baby to do the things that they're designed to do then? They were like, well, we need a plan. And I was like, we have a plan. We wait for the body and baby to do what they're supposed to do. And they were a bit stumped and didn't really know what to say after that. I was like, that is the plan.
Non-player
The body's design
characters.
is the plan. Okay. All right, let's move on to our next one before we lose the will. Okay, reduced fetal movements. Okay, so there is no, surprise, surprise, no randomized controlled data comparing induction versus expectant management. There is no data that shows that induction reduces stillbirth with reduced movements when there are normal CTGs and scans. So you shouldn't be being offered induction for reduced fetal movements when there are no other signs of issues. Okay, you are offered it because doctors would be less likely to be sued if there was a bad outcome when you have an induction than if you don't. Okay, and let's be clear, there is a significantly higher risk of you having a worse outcome with induction for you and your baby, more likely emergency cesarean, instruments on your baby's head, depression, trauma, affected bonding, affected breastfeeding, NICU admission for your baby. Okay, so as we've said in previous episodes, the Saving Babies' Lives were really pushing that if there was reduced fetal movement, that there would be a lower tolerance before there was intervention in an attempt to save babies' lives. It hasn't. Yeah, the data doesn't show that if you have reduced movements without any other signs, that induction makes outcomes better. What it does show is that it makes them worse. Not necessarily that more babies die. It's about the same level, but there are, you know, those knock-on repercussions, neonatal intensive care, depression, etc., etc. Okay.
Hypoxia,
yeah, hypoxic injury, brain injury to
big
your baby.
One.
Yeah. Pre-labor rupture of membranes. This is a favourite one. Okay, so if your membranes rupture and then you do not start labour. So I just want to point out the glaringly obvious elephant in the room here, that if you get a rupture of membranes before you are considered at term, okay, so before 37 weeks, they don't go, you got 24 hours before your suddenly infection risk has gone through the roof and we have to induce you. Okay, they will leave you weeks to wait. Weeks. So when you are at term, why do they suddenly go, oh my God, you've got to be induced now? And the windows where they used to say that have gone down without any evidence to show that it's improving outcomes. So it used to be that you could wait to see if contractions started naturally.
When I started midwifery, it was 96.
96 before that. This is the thing. It's like keeps going down. 96, 72, 48, 24, 12. Now it's like immediate in a lot of places.
Well, they say immediate. Yeah. They say, they call expectant management up to 24 hours. And nothing exists after that.
So guess what?
Not given away.
There is no difference in perinatal mortality with induction or not. None. Okay, so if you're being told that you need to have an induction to save your baby's life, that's not what the evidence shows. What the evidence shows is that there is a small reduction in neonatal infection. So the markers for infection, or the suspected infection, goes from 2.2% in induced compared to 3%. Okay, but it's important to understand that both of those groups were in a hospital setting. Okay, so they would have had hands all up in their business. They would have had checks to see what was going on, which we know is an independent risk factor for infection.
Already got that evidence.
And the other thing is important to notice that depending on the studies, it's whether there's actually a confirmed infection or suspected infection.
That's right.
Okay, so if they're using markers, so sometimes if the temperature is raised in the mother or baby, they thought they've got an infection, but actually it might be because they've had an epidural medication because of
100%
the induction medication.
Yeah.
Okay, so that difference is less than 1%, 2.2 to 3%. And remember, both of these were in hospital, so it had fingers up the vagina. So what I'd say is if you don't stick anything up your vagina, if you have a pre-labor rupture of membranes, if you don't have signs of infection, you don't have to have an induction if you don't want. Okay. NICE says, it's NICE guidance 1.2.10, if a woman has preterm, pre-labor rupture of membranes, do not carry out induction of labor before 34 weeks unless there are additional obstetric indications. Offer expectant management until 37 weeks. Why suddenly at 37 weeks?
Exactly.
Do you suddenly become a greater infection risk? No. Okay. 1.2.13. Offer women with pre-labor rupture of membranes at term a choice of expectant management up to 24 hours or induction of labor ASAP. Discuss benefits and risks. Take into account their individual circumstances. When you can wait for labor for weeks when you are not at term, why can you not wait when you are at term? Okay. The recommendation is not evidence-based. Your risk of infection doesn't suddenly...
That many of us who read research and have experience, we kind of side-eyed NICE guidance. But once they came out with that induction of labour guidance in November 2021, we realised that anyone who had anything to do with it was compromised, and literally we can put you all in the bin. because for them to change, especially that pre-labor ruptured membranes, that guidance, when that was changed, I thought, yeah, you clearly absolutely don't care about women and babies. You don't care. No evidence base whatsoever for that.
No, the research quality is low, apart from the evidence showing that there is no difference in the rate of death of babies when comparing induction and waiting, and that's moderate quality evidence.
So that's moderate quality, but they've ignored it. The only bit that is actually worth a look at, they've ignored.
Yeah.
In favour, again, it brings us back to the fact that there are major actors that are very invested in making sure that as many pharmaceuticals and instruments and theatre time and theatre staff are used as possible. You're a sitting target if you take yourself into hospital because your waters have gone.
Yeah. And the definite or probable slight increase in neonatal sepsis that we talked about, that change between the 2.2% to the 3.3%, was not statistically significant when the probably numbers were discounted. Okay, so like I was saying, sepsis can be suspected even when it isn't actually present, such as, and like I said, due to epidural or low blood glucose, or which happens due to the use of synthetic oxytocin, reduces the baby's blood glucose more significantly. A review showed a 1% increase in the absolute chance of uterine infection for those who chose to wait for labour. However, if recognised promptly, this can be treated with antibiotics if needed, with comparable outcomes. So there also is not strong evidence for the benefit of prophylactic antibiotics. So if your waters have ruptured and they're saying we need to give you antibiotics, there isn't good evidence for that either. So really, they should not be routinely used for pregnant women with ruptured membranes prior to labour at term, unless there is significant signs of infection. Antibiotics shouldn't be given either to the woman or to the baby, even if the membranes have been ruptured for over 24 hours. And that's actually in NICE guidance, NG195. If there are no signs of infection, antibiotics should not be given either to the woman or the baby, even if the membranes have been ruptured for over 24 hours.
Wow.
Yeah. And so 79% of people will begin labour within 12 hours spontaneously at term if their waters rupture, 95% within 24 hours. Okay, we're going to speak about that more again in a future episode to talk to you about what you can do, etc. But basically, don't let anybody poke anything up there, because that really does increase the risk of infection. You know, we have data showing that it's an independent risk factor for sepsis. Okay, so yet again, no evidence for improving outcomes with induction. Okay, let's go on to diabetes. Should we all guess together? Is there any evidence showing that induction of labour is beneficial for a woman with gestational diabetes? Do we think there is, or do we think there's not? Answers on a postcard, people.
Oh man. Yeah, answers on a postcard.
Well, guess what?
No, there's absolutely no evidence for any type of diabetes for there to be, unless it's uncontrolled diabetes.
Actually,
No?
there is no evidence showing that induction of labour is beneficial for women with gestational diabetes, whether your blood sugars are controlled or not, as far as I have found.
I know why. Sorry, the nuance of that. That's because it's gestational diabetes. So say if you've got untreated type 2, your glucose has been all over the shop from before you were pregnant, there are issues there. But you're right. If it's just gestational diabetes, your glucose isn't out of control long enough to make a difference to the outcomes.
Exactly. There is a higher baseline stillbirth risk with poorly controlled blood sugar, but there is no definitive research showing that induction will reduce that risk. And as Kemi's saying, really generally that increase in stillbirth risk is due to uncontrolled blood sugars early in pregnancy. So when organogenesis is happening, so when your fetus is forming, if the blood sugar levels are high then. Now, gestational diabetes doesn't happen until later on, when there are hormonal changes, which are caused by changes in the placenta that are making you more insulin resistant to try to get energy to your baby to help them grow. So it happens later in pregnancy. If you've had type 2 diabetes or you're a type 1 diabetic and that has gone well, type 1 diabetics wouldn't be undiagnosed, I would assume by that point. But if you've got type 2 diabetes that is undiagnosed early in your pregnancy, that can potentially increase the risk. Okay, but there's still no research showing that induction will reduce that risk. Okay, and it's important to understand that neonatal hypoglycemia, so low blood sugar levels, is more common with birth before 39 weeks. Okay. What does NICE guidance tell us? Well, NICE guidance states that if you have gestational diabetes, you should be advised to have your labour induced or a caesarean section if this is the best option for you before 41 weeks of pregnancy. You may be advised to have your baby earlier than this if there are complications. However, NICE guidance also states that there is uncertainty about the benefits and risks of induction of labour compared to expectant management, and that there is evidence that the risk of perinatal death, brachial plexus injuries, and the need for emergency caesarean are the same between induction and expectant management.
Oh my word.
Of course, they don't consider the long-term outcomes. They don't talk to you about the long-term outcomes or how you might feel about it as a mother. Yeah. And in terms of the Cochrane review, the most recent Cochrane review found a single study, with 425 parents and babies, and compared induction to awaiting spontaneous labour. Guess what? There were no differences in outcomes, including the number of big babies, including the incidence of shoulder dystocia, including the incidence of breathing issues, low blood sugar, NICU admissions. There was, however, more jaundice in the induced group. They concluded,
because their livers aren't ready.
Exactly. With the current evidence, we find it difficult to recommend mothers with well-controlled gestational diabetes to give birth in an obstetric-led unit with continuous monitoring and deny them the chance to have a home birth or one on a midwifery-led unit. In women with gestational diabetes but without specific medical conditions, induction of labour between 38 to 40 weeks of gestation is associated with an increased risk of caesarean. The biggest difference with induction concluded by the Cochrane review with induction with gestational diabetes was that babies would be smaller by the average weight of a medium tomato.
Oh, man.
I mean, does that make it a good reason to have one? No. And actually you could potentially be disadvantaging your baby, because what we're seeing is that reduction in birth weight of a baby actually is of essential stores that they need to help them to cope with life outside of the womb, that help them to cope with the transition to feeding, to breastfeeding, and the time for colostrum and then the milk to come in and then to be getting enough calories. And if you are inducing before your baby is ready, their stores are reduced. But if you are inducing before you are ready, and remember, you know when you and your baby are ready because you're in labour. So if you are having your labour induced, you're not ready and your baby's not ready. It takes time for those things to establish. And when you have induction, it messes with the physiology that we've spoken about in season 1, episode 1, and it impacts the chances that your breastfeeding is going to be successful. You're not getting the same peaks of oxytocin. You're not getting the same peaks of prolactin. It has an impact. Okay. So for no benefit, making your baby smaller when they don't need to be, do you want to have an induction for gestational diabetes? The data doesn't show it's good. Okay. How about estimated birth weight?
Oh, fuck off. I'm not having... Can we stop? Let's stop. Please. Oh, okay.
No. I'm just going to say it's not a valid reason for induction, okay? Estimated birth weight is wrong huge amounts of the time. And when you get a scan for estimating how much your baby weighs, it goes to the nearest gram as if it's accurate. But it's not. We've seen in the big baby trial that they incorrectly guessed 60% of the time.
60% of the time.
If you flip a coin, that would be more accurate than having an ultrasound to determine if your baby's big or small. So please, if someone's telling you they think your baby's big or small and that's the reason you need to have an induction, no, just no. Just no. It's not evidence-based. Their tools to determine the size of your baby are inaccurate. Nobody knows how big your baby is until you've put them on a scales when they're out. And that can wait.
You weigh
There's
it.
no rush to do that. Enjoy that time snuggled up with your baby.
No.
So stay snuggled up.
My grandchildren
Wait for that.
were never weighed. Let's say that. We guessed the weight.
Yeah. It's fun to guess, isn't it? I like a bit of a...
We just guessed it.
Bit of a guess. Okay. For fetal growth restriction, nice guidance, 1.2.23. And we've just alluded to this earlier. Do not induce labour if there is FGR with confirmed fetal compromise. Offer caesarean birth instead. That's it. Okay. So you don't want to be trying to pound your baby through with induction if they have got a problem. If fetal growth restriction is not identified, stillbirth rate rises to around 1.98%. If it is identified and managed, that is 0.97%. Okay, and those are general figures. So that will change according to the severity of the growth restriction and will change according to the gestation, because obviously later gestations, babies are trying to demand more from the placenta. From the Digitat study, if you are equal to or over 36 weeks, there were no significant differences in adverse neonatal outcome composites for FGR babies with induction or not. There was no difference in perinatal death. Induction does not improve short-term or 2-year outcomes in fetal growth restriction at term. Okay, so fetal growth restriction, not a reason for induction. We've got Kemi's favourite. She's going to lose the will to live. I've got low pape on my list next.
Oh, man. Can I tap out for this section?
Losing the will. Yeah, I feel like we're in an appointment with a consultant right now, and they're just saying to us with each one, yeah, this is a reason for induction, and we're having to justify why not, you know. And actually, this is an important point to make. You don't have to justify your reasons as to what you want to do. You don't have to go into your consultant with evidence. They're not going to care to read it most of the time anyway. They're pushing their own agenda for what feels safe for them for all of the psychological reasons we've said in the last episode. You may get a gem of a consultant. Okay, there are some out there that are interested and want to learn and want to better their practice. But most of the time, no. The arrogance is so overwhelming, they don't want to listen to anyone else. Okay, so low pape without evidence of any other complications, not a medical reason that would indicate induction of labour. There's no evidence that induction of labour would improve outcomes with low pape. There's also no strong evidence that ongoing ultrasound surveillance is helpful for people with low pape either. Okay, so if you are being told to come in and have, surveillance to monitor the safety of your baby because of your low pape, and then you're getting induction pressure on top of that and it's stressing you out, know that the research doesn't show it makes it safer. So save yourself the trouble. Stay home unless you're concerned. Yeah. How about small for gestational age? As we discovered from Kemi last week, they've moved the goalposts, not just, I thought they'd just moved the goalposts for small for gestational age, but you said they've moved them for fetal growth restriction as well, which is just mad on no evidence. Well, guess what? There's no evidence of benefit for induction.
No.
No, funny that.
Can't believe it. So they're making suggestions even though there's no benefit for mothers and babies. I can't believe that, Shellie.
Yeah.
Do you think it benefits their bottom line, though? Do you think it gives them a reason for being, a sense of power and control? A way to torture mothers and babies. How about that?
Yeah. No nice recommendation for induction. If your baby's just small and not growth restricted, they do not have an increased chance of perinatal mortality or morbidity. There is no reason to induce. And I think it's important to understand, because maybe people don't realise this, because often because they just don't think about it. We're not kind of taught about anatomy and physiology really that much as we're growing up. So only nerds who are interested in it actually think about these things. But your baby inside your uterus is being in a nice warm, they're like in a little warm flotation tank, just a degree above body temperature. They're nice and snuggly. They're kept warm 24/7. They're fed intravenously, basically 24/7. Okay, all their waste products are taken back to the mother's body to sort. All of their nutrients are coming straight into their bloodstream. So they don't have to use effort to eat. They don't have to use effort to learn how to eat. They don't have to use effort to digest. They don't have to use effort to metabolize. The liver and the kidneys are not working the same in a fetus inside you as they are when they come out into the real world. So a huge amount of energy is expended in newborns in figuring out how to eat, getting the food out of the breast or the bottle, wherever they're feeding from, digesting that, then metabolizing that into something that they can use. In uterus, they don't have any of that. And they're not having to expend energy to stay warm because they're being kept warm.
Yeah.
So the demands on a fetus, if the placenta's working fine, the demands on a fetus inside the uterus are far lower than they are on a baby outside. So why would you want to evict them and make them have to do all that hard work for stuff that they're getting handed to them on this lovely, comfy, floaty plate that they're currently in? We want them to stay in there, to lay down the white fat under their skin for their glycogen reserves for birth, so that they've got brown fat stores, so they've got these energy stores for the stress of labour, for their transition from colostrum to breast milk, and for their brain stores, for them to have a healthy brain. If we interrupt it means their brain doesn't have enough fuel, doesn't have enough food to cope with the hypoxic event that is labour. Induction in pregnancies that are complicated by small for gestational age at term. Okay, I would say, are they complicated or are they just small? But anyway, induction is associated with a higher risk of instrumental birth without improving neonatal outcomes. Okay, so it makes it more risky for your baby without any benefit. So no, small for gestational age is not a good reason for having an induction. Not a good reason. Okay, what about large, big babies?
Well, something's got to be evidence-based of these harebrained suggestions. Maybe it's this one. Yeah?
No significant difference in shoulder dystocia, no significant difference in nerve injury, no difference in mortality for mothers or babies. What does NICE say? NICE says you should be offered induction or expectant management, even though there is no evidence that induction makes things better. Okay, I'm going to put a link in the show notes to an Instagram live discussion that we had around the Big Baby trial that you can listen to, where we went into detail discussing the study in more detail. Because if you believe the propaganda that they put out, you would think that it would be safer to induce your baby, even though that's not what the results of the trial actually showed. And they hid things in the kind of the extra bits in the trial.
Appendices.
So not in the kind of appendices, that's it, not in the main body of the trial. But if you look in the appendices, they actually showed that with the data set that they had, which was quite large. I can't actually remember the figures. We talk about it in the live, but it showed that there was a 10% increase in risk of depression with induction. What's important to know, actually, that in the trial, the standard care group, 70% of them were still induced. So really it was a comparison between 100% induction and 70% induction, rather than induction and truly waiting for your body to be ready.
Yeah.
Yeah. There was also a difference in breastfeeding outcomes, the number of babies that were breastfeeding. There was a 5% difference in the difference of breastfeeding outcomes. So 5% fewer babies were breastfeeding. I think it was when they left the hospital, who'd been in the more induced group. Okay. And that they didn't say in the trial that there were these significant negative outcomes for having an induction. They said there was no significant difference going badly for having an induction. But what they did do was fudge the results. They had to fudge the results in order to make the difference significant in terms of shoulder dystocia. So they fiddled around with the data so that they ended up with a 1.4% difference in the incidence of shoulder dystocia. So even though we saw 10% change in depression, 5% change in breastfeeding, they weren't as significant apparently, because they made induction look bad.
Oh wow.
Do you see what I mean?
Yeah,
so
really
go listen to that live. Yeah, go and also other things. Readmission. So readmission into hospital, 13.6 in the induction group. In the standard care it was 10.2. And then there was 12.3% that babies needed further medication. compared to 9.9% in the non-induced group. Then antibiotic use, 11.8% in the induction group compared to 8% in the standard group. So when you dig into the appendices, you see that actually there are quite a lot of downsides to the induction group that they claimed were not significant. But yet the difference in shoulder dystocia was less than all of the things they claimed weren't significant. And it only became significant when they fiddled around with the data. So listen to our live about that on Instagram. And also Dr. Sarah Wickham did a good blog post about it.
She did.
Where I think she said something like, it's almost as if the people that were doing this trial wanted to prove that induction made outcomes better when it didn't, and manipulated the data to get what they wanted to prove, even though the data didn't prove that. Funny that. Okay, another reason, IVF. Is IVF a good reason for induction? Does it mean that outcomes are going to be better? No. There is no RCD data showing induction improves outcomes for IVF babies. There's no evidence, in fact, that IVF treatment means that the placenta will not work as well at the end of pregnancy. And if you're told that, it's a lie. Okay. And you might be told to schedule induction of labour at 38 to 40 weeks because of evidence that IVF babies may be at increased risk of stillbirth. However, a lot of the evidence does not show an increase in stillbirth rates for IVF babies. A single study did, but it did not state the dates at which the losses occurred. Okay. And actually, when you dig down into it, the risk of stillbirth in IVF pregnancy appears to be limited to before 28 weeks of pregnancy, not beyond. So induction would not help reduce that stillbirth risk.
Exactly. Okay. We shouldn't be even having the conversation because we wouldn't be inducing at 28 weeks. And that's one of the main things that I hope people that have assisted conception can take comfort in. I know it is always a scary thought that you might not raise your baby and die before them. I understand that. But it's with the up to 28 weeks statement, it is because the 1 in 1,000 increase in the chance of fetal loss is related to the fertility of the fertility problem that made assisted conception necessary in the first place. So I just always have to mention this for when we've got a family where 2 women are going to be giving birth to and raising a child. If they've used assisted conception because they are 2 women, not because of fertility issues, that up to 28 weeks rule is even blown out of the water. Yeah, they're just the same as the rest of the population. Yeah.
They just want to scare everyone into having an induction, even when they don't think about the reasons behind it. So it's important to dig down into the reasons behind why things are thought. It is considered that some conditions may be more likely to occur, though still be rare in IVF pregnancies, like placenta previa, like placental abruption, accreta, cord insertion abnormalities, but none of those are going to benefit from induction of labour. Okay, so none of those are a good reason for induction of labour either. And also, we do see that gestational diabetes and preeclampsia appear to be slightly more prevalent in IVF pregnancies. Still not hugely prevalent, but they may be more prevalent. But if you have either of those, okay, then you just need to go on to consider induction for those reasons or not. Not because of IVF, because IVF isn't a valid reason. So then is gestational diabetes a valid reason? Well, you've just heard what we've said about gestational diabetes. No, and then you also heard previously when we were speaking about preeclampsia in the last episode, okay, that might be something you want to consider what's going on. Okay, but it's your choice. Okay, the other favourite that usually gets thrown in with the week of conception, your placenta has got a sell-by date. It's going to fail. It's going to die. Oh my God. Okay. So a review of the available evidence indicates that the placenta does not undergo a true aging change during pregnancy. There is, in fact, no logical reason for believing that the placenta, which is a fetal organ, should age while the other fetal organs do not. The situation in which an individual organ ages within an organism that is not aged is one which does not occur in any biological system.
Is that my marvellous Professor Fox? Yeah. He ain't got time for this shit.
No, exactly. The persisting belief in placental aging has been based on a confusion between morphological maturation and differentiation and aging, a failure to appreciate the functional resources of the organ, and an uncritical acceptance of the overly facile concept of placental insufficiency as a cause of increased perinatal mortality. Dr. Fox, 1997. Okay, so no. It's not your placenta. There's no reason to think your placenta is going to age. You don't, when you're having your baby, think, "Oh, my newborn baby's brain is so old. Oh, their kidneys are so old." The placenta is their organ. They've created it to sustain their life and create the bridge between you two as humans in order to facilitate their growth and their life. If there is an issue with blood flow to your placenta, that's different. Okay? But your placenta isn't just going to suddenly age and crumble and die. There's no evidence to show it. And Dr. Sophie Messager has an excellent blog post, The Myth of the Aging Placenta, where she's dug into all the research about that. So I highly recommend you finding that and having a look at it.
Yeah.
Okay, VBAC. You're trying to have a vaginal birth after cesarean. Well, guess what? NICE guidance, NG207, does not recommend routine induction for VBAC, which is interesting. It states, women with a previous cesarean should be counselled that induction increases the risk of uterine rupture and emergency cesarean birth. The licensed medication used for cervical ripening, dinoprostone and misoprostol, are contraindicated in women with a uterine scar because they increase rupture risk. If birth needs to be expedited, does it? Women should be offered a choice between induction or planned repeat cesarean with full counselling. So VBAC with spontaneous labour should be preferential. Okay. Actually, I haven't closed the quote marks, so I'm not sure. I think I probably put that last bit. I don't think NICE said so VBAC with spontaneous labour should be preferential. I don't know if they actually said that. That might have been me. That would be wishful thinking if it wasn't there, wouldn't it?
And also, I'm sure we'll mention it, but synthetic oxytocin also can cause harm. It's the whole hyperstimulation piece that can occur, but and you ought to be aware that cervical ripening is more associated with hyperstimulation and with uterine rupture than even synthetic oxytocin. So it's not okay to say, I'll just have the beginning bit, but in actual fact, there's a doubling of the risk, isn't there, with just the prostaglandins alone?
Yeah, I've got the stats here. And also, remember to our last episode when we were talking about that, the previous kind of versions of inductions that were created by obstetricians through the years. You can crank open a cervix, but if the uterus isn't ready, well, you'll have an open cervix. And then nothing else will happen.
Nothing else, yeah, exactly.
Yeah. So data shows us that the uterine rupture risk in spontaneous VBAC labour is around 0.2%, so 99.8% for it not to happen. The perinatal death risk is around 1 per 1,000 births, which is similar to the level of first-time labour. So it's, standard across the board, really. Induction consistently increases rupture risk compared to spontaneous labour. So induced, you get a 0.54 to a 1.4% risk of rupture with prostaglandins. Dinoprostone, the rupture risk is around 2% in some studies, and some report even higher, up to 2.45 compared to 0.77 without them. Misoprostol, or it's called Cytotec in America, the risk is up to 6%. So you can see why they're contraindicated. Just because they're contraindicated doesn't mean that people don't try to do it anyway. Okay, so you need to be on. I'm being really serious here because
evil. It's so evil. How can you justify that as a professional?
No, and I'm not kind of making excuses here, but they are very busy. And I think they often just don't look at people's notes and they just, go ahead with things because it's, they're in like automatic mode and they don't think about the consequences. Okay. Now,
but they see the consequences.
Yeah, but they blame the consequences on the medication and they just say it's a known risk factor. They don't take responsibility for the fact. It's like, what is it? Guns don't kill people. Did you ever see that video? Guns don't kill people. People kill people. Yeah. Misoprostol don't kill people. The people giving the misoprostol kills people.
For real.
Sitting there on the side, it's not going to increase your uterine rupture risk. If you put it in your mouth,
exactly,
or you give someone permission to put things up your vagina, you are the person giving the permission for that. We've got to take responsibility. If you don't want to have something, if you feel you can't say no in the moment, make sure you hire somebody that can say no to help you do it. Okay. And, mechanical dilation methods, which maybe, sold as if they're safe, it's going to be 0.8% compared to spontaneous labour. So even with mechanical methods that are pushed as safer than chemical methods, they are still doubling your risk, if we're going to say it the medical way, rather than just waiting for spontaneous labour of uterine risk, even if your labour is then not augmented. Okay. And then if we're adding augmentation on top of that.
That's just the cervical ripening alone for Dilapan rods.
Yeah, 0.8 compared to 0.4.
Balloon catheter as well.
Anything that's putting pressure, mechanical methods. And then, like we say, so if that opens your cervix, okay, and then your body's like, well, okay, you forced my cervix open, that's been bloody uncomfortable, but, I'm not ready yet. I'm not gonna start labour. Well, from our previous episode in the history where they did artificial rupture of membranes, they break the membranes, and now you've got increasing infection risk. Your body's not ready. So then the next thing is going to be augmenting. And the augmentation chance is 0.9 to 1.9.
Wow, there you go.
Yeah.
More than double.
So whatever you're doing with induction, it goes from doubling to tripling to 15 times increasing your risk of uterine rupture. The thing that they're probably telling you need to have an induction for to reduce. Kemi and I were just talking about this before we started recording, actually, because I was just a bit like, I don't understand why they would be telling you need to have an induction because you have a VBAC, because all of the evidence shows that induction for VBAC increases the risk. It reduces your VBAC success rate. It increases your chance of having another cesarean. Why are they doing it? And Kemi said often it's because they're saying that your baby might get big and that might cause an increased risk of uterine rupture. But that's bollocks too. There's no evidence to show that.
Yeah, we've already covered that.
None.
Yeah.
There's no evidence to show that, but there is evidence to show that these induction methods do increase your risk. And, I want to be clear, the risks are still low, but they're there. And do you want to double a low risk? From 0.4. And, if a risk of your baby dying is 0.1, why are you then wanting to bring it up? Your baby's more likely to become distressed with induction. Your uterus is more likely to struggle to create effective contractions, even when you've got medications forcing it to do so. And studies in hospital environments consistently show that spontaneous VBAC success, it's around 75% in the UK. I think it's now dramatically lower. From the last few infographics you shared, Kemi, I'm sure you had one the other day where it was close. It was 13%.
Yeah, that's right. Because I even forgot I'd shared that. But
VBAC.
I still thought the lowest I'd shared was 20%.
I saw that the other day.
But it's 13%. And I don't know any there is no hospital in the UK that has a 75% rate. And I think when I was a midwife in training, there were, but definitely not now.
Yeah. And if you then introduce induction into that, you're then dropping. So from their stats of 75%, it then drops to 50 to 65%, depending on the method used. Alongside higher rates of emergency cesarean, instrumental birth, fetal distress. There is no evidence that induction improves outcomes in VBAC pregnancies in general. Okay, so most recommendations for it are risk management decisions for the hospital rather than based on good evidence. They're based on your care provider's fear. They're based on their convenience. They're not based on evidence that it's going to make it safer. And often, if they can't corner you to induce you on reason of VBAC alone, they'll present another reason. I had this woman. Firstly, they said they wanted to induce her and led her to believe that her baby might die, and kept her in the hospital for 5 days. I went in to see, and I was like, why is she here for induction? You've left her alone. She's panicking that her baby's dead and nobody's listened in for days. You just left her in a room on her own. And why is she here? Why are you telling her that her baby might die? And the doctor was like, oh, it was because of her BMI. And so you now know that BMI is not a reason. There is no evidence to show that induction improves outcomes for BMI. Any other reasons that you've got her here? Or her gestation. I was like, well, she's not even 41 weeks yet, let alone 42. So that's not a reason. Let's throw that one out the window. Any more? Oh, because it's the feedback. And I questioned this consultant into silent submission. It's probably one of my, I'm not going to lie, proudest moments. I went home on such a high because I really felt for this woman. I came in, she's there crying over a limp bit of toast, thinking that, in this room for days, being left alone, thinking her baby's dying, and it was so cruel. And I was like, you could just be at home, this over exaggeration of risk broke her. Yeah. Broke her. Yeah. And I was like, you fuckers, you absolute fuckers. You have got no good reason to have her here. You're just putting her on an unnecessary conveyor belt of harm. They were like, the risk significantly increases in stillbirth. I was like, well, that's not my understanding of the stats. Here are the stats that I understand.
Yeah, exactly.
I was like, do you know any different? And they were like, no. And I'm like, well, that's not really a significant increase in risk, is it? And then I was like, no, her high BMI is not a good reason for induction. No, having a VBAC is not. I'm like, you increase the risk of VBAC. Why is that a good reason for induction? And she actually said, well, it isn't. I was like, okay, then we'll go home. And then they wanted to give her a sweep. They wanted to give her a sweep.
Yeah, on the way out. Or can I just poke my fingers up your vag on the way out? These malevolent fuckers. Okay. And, for having her being held hostage in there for 5 days, they would have charged on. That's how many days would they get paid for this woman to be lingering in that place, crying her eyes out? And then what does it cost society for most of you that don't have an advocate and don't care to get informed or any of that, you are just making huge amounts of money hand over fist for the NHS, and what do you and your baby have to show for it? Decades of trauma. What's the benefit after the assault that you allowed by maternity services, maternity care providers? Yeah, I'm not playing with you guys. You're all adults. Take responsibility.
It is an insult to your body, to your system, to have any form of induction, from sweeps all the way up. And we're going to go through the different things and try to help you to understand the risks of each different one in future episodes. But as you can see from this list of things, I mean, we went through all of the things I can think of. I don't know if you think we've missed anything, Kemi, but,
nothing significant. Someone will come up with something and we can address that in future episodes.
Yeah, we will. Yeah, please comment down here if there's another reason you've heard or you've been given that you should have an induction, and we will follow up with it on a future episode, I promise. As you can see, for many of these conditions, randomized control trials either show no benefit from induction, or the evidence is extremely uncertain, or the difference between having an induction or not is very minimal. There's no evidence whatsoever, or the evidence actually shows that induction is likely to cause more harm than good. I mean, honestly, I'm really hoping that people see this episode and recognise that the do no harm part of medicine has gone well and truly out the fucking window. When the induction rate is now definitely over half of all pregnant people. And probably, as we were saying in a few episodes ago, closer to 80% of people when we put sweeps in there as well, which is a form of induction. Okay, so sometimes induction may reduce certain maternal complications, but that does not always translate into better outcomes for babies necessarily. And in some situations, particularly before 37 weeks, induction increases neonatal respiratory problems, NICU admissions. We also know from Hannah Darlin's study that induction before 40 weeks has significant impacts on children's long-term respiratory, immune health, and also on their cognitive function, their brain and their learning abilities. Okay, so what does all of this mean? Over the past decade, we have seen large increases in induction, we've seen large increases in caesarean birth, and we've seen a significant drop in vaginal birth in the UK. But these increases have not produced dramatic improvements in mortality, and maternal mortality is significantly worse. Stillbirth rates were already falling long before modern induction became common, and for many of the reasons people are told they need an induction, there is limited or uncertain or contradictory or no evidence that it improves outcomes. In some situations, induction may offer benefits. In others, it's going to introduce new risks. And in many cases, the differences between the two are very small, between watchful waiting, and not. So the most important thing for you all to understand is that induction is not automatically the safest choice, even if it's being sold to you as if it is. And waiting, equally, is not automatically dangerous, which is often you're told it is. Both options have potential benefits and potential risks, and what really matters is informed choice. You deserve to understand the absolute risks, the possible benefits, the potential harms, and the quality of evidence behind the recommendations that you are being given, because ultimately the decision is yours. It belongs to the person who is giving birth, not to hospital policies, not to fear, not to made-up statistics or statistics presented without context, not to skewed statistics that make it sound scarier than it is. It belongs to you. So please, please, untether yourselves from fear, the propaganda, and the need to please people other than yourselves. Okay? And next episode, we're going to be talking about the intervention of late pregnancy monitoring. So ultrasound, pre-labour CTG, non-stress tests, Doppler scans, what they're actually looking for, what information can they give us and what information can't they give us? Do they truly improve safety? And unless Kemi has anything to say, we'll see you next time. Kemi?
Just want to add, and I may have mentioned this before, but this is really important. This is about Shellie saying that obstetrics, maternity care, and it's malevolence. They will kick the can down the road of responsibility. So whenever I'm speaking with teachers, experienced teachers, not the brand new ones, they wouldn't know, but experienced teachers have been there for a while, preschool teachers, nursery teachers, high school teachers, they all say the same. They've noticed that larger proportion of their classes are children with cognitive development challenges, even to, when they become clean and dry, when they enter school, they're finding huge differences. And because obstetrics is great at saying, no, look over there, they're not realizing, well, some are realizing it's the birth event, but many are not. So as you can see, obstetrics really never own up. They just don't have the morals to do it. But you are the person, you parents are the people, the only potential protectors of this current and future generations. I know it feels like a heavy weight to carry, but it is yours. You're the ones that are going to need to get up to speed and stop presenting yourselves and your children for harm by maternity services.
Please reach out for support with us, please, because it will make a big difference. I just got off a call before we started recording this morning with a mum, who'd listened to the podcast, who'd reached out for support. And she very sweetly said at the end, you're the first person I've spoken to who's actually talked sense to me, made me feel confident that I can make a decision that's right for me, that hasn't questioned it or claimed I'm being irresponsible or anything like that. You've presented the information and I now feel that I can make the choice that's right for me. So please talk to me, Kemi, because we offer to do that. And I've not had anyone regret having a call with me.
No,
I've never had anyone regret having a call with me, So please, please, please reach out and hope you have a good week. And we will see you next time, everybody. Bye-bye.
See you next time.
You can sign up to the Birth Untethered mailing list from the link in the show notes, become an Untethered Rebel, support the show, and join the growing community that meet together online each month to share collective wisdom, support one another, and also to receive extra resources that supplement podcast episodes. The information shared in this podcast is for educational and informational purposes only and should not be construed as medical advice. The views and opinions expressed by guests are their own and may not reflect those of the hosts. This content does not replace professional medical guidance.